Hello everybody, welcome to my presentation on the effects of skin-to-skin contact on newborn breastfeeding. My name is Abigail Tarango. I'm a student of Arizona State University. This class is for Nursing 318, Nursing Research and Evidence Translation, and my professor is Dr. Fries. First, we'll address the clinical practice problem and some background information. Skin-to-skin contact has been shown to have many positive effects on both mother and baby, especially in regards to breastfeeding. There are a lot of skin-to-skin regimens found in most U.S. hospitals, but skin-to-skin contact might not be implemented early or immediately, or it might be interrupted for reasons aside from medical or obstetric complications, such as family being around wanting to hold the baby, or staff members wanting to kind of hurry up and get the height and weight done, kind of getting that routine infant care completed. UNICEF UK noted that skin-to-skin contact does help regulate the neonate's heart rate and breathing, stimulates digestion and interest in feeding for the neonate, and it stimulates the release of hormones to support breastfeeding for the mother. According to the World Health Organization, a recent study found that 90 minutes of uninterrupted skin-to-skin contact, where the baby is dried and laid directly on the mother's bare chest after birth, maximizes the chance for babies to be physically ready to breastfeed. In addition to this, there are lots of other reasons that skin-to-skin contact should be implemented, such as temperature regulation and the secretion of additional hormones for the mother to kind of help with stopping postpartum bleeding. Next, we will address our PCOT question. So my question was, in full-term newborns, what is the effect of immediate and prolonged skin-to-skin contact in comparison to those with routine skin-to-skin contact on improved breastfeeding rates upon discharge from the hospital? My population is full-term newborns. My intervention is immediate and prolonged skin-to-skin contact. My comparison is routine skin-to-skin contact. My outcome is improved breastfeeding success rates, and the time frame is during the hospitalization of the infant. The first step in looking at and utilizing evidence-based practice is finding the evidence and really researching that literature. So we do have several search strategies that we can utilize when we're looking for articles and journals. When I was first looking for the information for my project, I had researched breastfeeding full-term newborns and skin-to-skin in the ASU library. I did not put any parameters into that search, and I yielded 238 results, so quite a few. There would be a lot to sift through there. So after doing some tweaking and adding parameters, taking away parameters, I did this 6 times, and my final search yielded 13 results. I did have parameters set, including full text online, open access, peer-reviewed journals, the year range from 2018 to 2022, and articles. This time I did search a different phrase, and so I had searched the effect of skin-to-skin and breastfeeding and full-term newborns. Again, this yielded 13 results, and so it was a lot easier to sift through the information that I was provided, and I was able to actually find information that was helpful in answering my PCOT question. The first article appraised was authored by Safari and colleagues in 2018. The name of the study was The Effect of Mother and Newborn Early Skin-to-Skin Contact on Initiation of Breastfeeding, Newborn Temperature, and the Duration of the Third Stage of Labor. It was published by the International Breastfeeding Journal. This was a quasi-experimental, level 3, non-randomized trial. The sample consisted of 108 mothers, with the intervention group having 56 participants and the control group having 52 participants. Low-risk pregnancies were included, and newborns required an APGAR score of over 7. The participants were recruited between February to May 2017 from the Haller Maternity Teaching Hospital in Erbil, Iraq. The control group had routine infant care provided with skin-to-skin contact initiated afterward, whereas the intervention group had pretty much immediate skin-to-skin contact right after delivery. The independent variable was the time taken for initiation of skin-to-skin contact after birth. The dependent variable was the initiation of breastfeeding, newborn temperature, and duration of the third stage of labor. 48% of the intervention group versus 46% of the control group achieved successful breastfeeding. There were no statistically significant differences between the control group and intervention group regarding the first feeding duration. According to Safari and colleagues, breastfeeding initiation time after birth and the duration of the first feeding was recorded, and the latch scale was used to assess the success of breastfeeding in both groups. Any degree of assistance provided by the researcher during the feeding was reported. The axillary temperature was taken 30 minutes after birth, and the duration of the third stage of labor was recorded. The sample size of 108 was adequate, and the researchers effectively documented their encounters with the statistical evidence. The information is transferable, which increases its trustworthiness. Overall, the information does appear to be valid, but further testing should be done, and biases should be noted, like the fact that this was not a randomized trial, so it is kind of limiting in that way. These findings do indicate that there are slightly higher rates of effective breastfeeding after immediate skin-to-skin contact. The second study appraised was authored by Jiazhen and colleagues and was titled The Evaluation of Effects of Skin-to-Skin Contact on Newborn Sucking and Breastfeeding Abilities, a quasi-experimental study design, and was published by Nutrients. This again was a quasi-experimental level 3 non-randomized trial. 52 mother-infant dyads without medical or obstetrical complications were in both the intervention and control groups for a total sample size of 104. The study took place from January 1st through July 30th, 2019. Consecutive sampling was used to recruit the participants who had undergone natural childbirth in the National Taiwan University Hospital, Hsu branch. The study's independent variables were the time taken to initiate skin-to-skin contact after birth and the duration of skin-to-skin contact. The dependent variable was breastfeeding success rates. According to the article, the researchers used a questionnaire for basic information about the mother and baby, and the infant breastfeeding assessment tool and breastfeeding self-efficacy scale short-firm were used. The scores were collected at 4 times, at 5 minutes after skin-to-skin contact, after skin contact had ceased, which was 25 to 30 minutes in the control group and 60 minutes in the intervention group, 24 hours after birth, and before discharge, which was typically 3 days at age. 67.3% of the newborns in the intervention group had successful breastfeeding after skin-to-skin contact, whereas only 28.8% of the newborns did in the control group. So the intervention group did result in a higher average with the infant breastfeeding assessment tool score at different times. Evaluation showed that breastfeeding ability and sucking ability scores increased with time for both groups. The timing of the participants' enrollment in the intervention and the control group completed in different months might be a limitation affecting results, and then socioeconomic effects should also be considered when we're thinking about the results of this study. The results did indicate that the intervention group had a higher breastfeeding success rate after immediate skin-to-skin contact for 60 minutes. 16% of the intervention group compared to 15% of the control group exclusively breastfed upon discharge. Now for the proposed practice change. The intervention proposed will be immediate and prolonged skin-to-skin contact after delivery. The intervention would be utilized in labor and delivery hospitals or OB units. New routine skin-to-skin contact policies will be changed to implement the immediate and prolonged skin-to-skin contact if the mother and the neonate are stable. Expecting mothers will be educated about the policy and the benefits of the intervention, especially at admission, but if we can educate them about this during their routine OB visits, that would be great as well. One thing to keep in mind is that many hospitals already have policies in place that implement early skin-to-skin contact, so in those cases, it's going to be important to determine how long the skin-to-skin contact is maintained. This proposed change will be more for those hospitals or units that don't implement immediate or early skin-to-skin contact, but it could also be used to make sure that skin-to-skin contact has a long enough duration to really provide the best effect for the babies and mothers. So now we're talking to the organizational leaders. In this case, we're going to be talking to administrators, unit managers, leaders, We could potentially talk to like the CEO when we're actually trying to implement a policy. However, they're not going to have a ton of input a lot of times in this kind of situation. So, stakeholder input is going to be very highly considered when we're determining the best way to educate staff on the intervention. If stakeholders disagreed with the intervention, we would try and come up with a different proposal. So, something like early skin to skin contact instead of the immediate skin to skin contact, kind of trying to come up with a middle ground there. Questions that we might ask would include: does your facility use evidence based practice? If so, how is it utilized in promoting breastfeeding? If not, will you share the reason why evidence based practice is not used? Does your facility utilize the best practice for implementing skin to skin contact in new mothers and babies? What is the current policy for routine skin to skin contact? And what are the rates for successful breastfeeding upon discharge? We'll also talk to the clinical experts, which will include lactation consultants, midwives, practitioners, possibly charge nurses and unit leaders. We're going to ask them what their educational credentials are, how much experience they have, what the current best practice is when utilizing skin to skin contact in mothers and newborns. We're going to try to also figure out where that answer is coming from. And then, what is the clinician's experience with promoting breastfeeding to new mothers? Determining patient preferences and values is going to be important when we're utilizing evidence-based practice into an intervention. So in this case, I would like to implement paper questionnaires and in-person interviews prior to their hospitalization, hopefully during their routine OB visits during the last 6 to 8 weeks of pregnancy. Questions that we might use to determine their previous knowledge could include: what information do you currently know about breastfeeding? Have you breastfed before? Have you been told about the reasons why skin to skin contact is utilized? And do you have any concerns about initiating skin to skin contact after delivery? Implementation and marketing. So, staff education and interactive in-services are going to be very important in making sure that the staff is fully educated on this intervention, as well as notifying the organizational leaders and the staff members about this change once we've already introduced the clinicians to the intervention. I would like to add pamphlets and posters in the OB unit and rooms for both clinicians and patients to see. And then patients will also be educated upon admission about the benefits of immediate and prolonged skin-to-skin contact immediately after birth. Evaluation plans. Exclusive breastfeeding rates and breastfeeding self-assessment scores upon discharge should be collected and evaluated before and after the new policy is implemented. A review should be done 3 months after the implementation of the intervention to determine if there was any change in breastfeeding success rates upon discharge. A review should then be done quarterly or biannually to see the effect that the intervention is making on breastfeeding rates.